Are we ready to go then?
Yeah, we're live
now. Okay. Right, welcome everyone. This is the final meeting of the Adults and Health Scrutiny Board for this civic year. Apologies for the slight late start, and thank you everybody for coming. We're a little bit down on councillor numbers this evening, and I think that is largely to do with the proximity of this meeting to the local elections and people's other commitments. So can we, who do we have apologies from, John? We've got Councillor Khan, Councillor Patterson,
Councillor Lonsdale,
Councillor Lonsdale,
and Andy Smith as well.
And Andy Smith. Okay, thank you very much. So are there any, we don't have any late items. Do we have any declarations of interest? No. And do the councillors present accept the minutes as presented as a true record of the last meeting? Yeah. Thank you. Thank you very much. Right. So we'll move on then. Our first item this evening is the Urgent Treatment Centre review update. That's Daniel Webster and Zara Jones. Thank you.
Hi, I've been to the committee before, but just in case anyone doesn't know who I am, I'm Zara Jones, Executive Director of Strategy and Planning at the ICB, and Dan is our Programme Director for Urgent and Emergency Care. So Dan is going to present some of the slides that we've got on the screen, but just by way of introduction, when I was last at the committee, we talked about A&E performance and discharge. Urgent treatment centres is a really key part of our overall urgent emergency care pathway. So it's always bearing in mind some of the conversations we had last time about some of the operational challenges we face, meeting the targets that were required over the next 12 months. The UTC provision, as we call it, is really key in helping us to perform, helping us to make sure that we've got accessible care across that pathway in different parts of the city and the county. So just really key, and it'd be really good to get your feedback once Dan's finished the slides around the review that we're undertaking and hopefully the positive impact it will have on residents locally. So Dan.
Yeah, of course. I mean, hopefully you had the opportunity to read the slides, but I'll talk you through them anyway, if that's okay. Just have the next slide, please. So this is really just an opportunity just to refresh your memories really about what UTCs are, the hours of operation, and what clinical conditions that our UTC clinical colleagues can also support. So we've just tried to give you a quick outline really, just to refresh your memory about what UTCs are and how they do support the system across Derby and Derbyshire. Now they do also support our A&E departments as well in making sure that these patients can be treated in probably more appropriate settings than an A&E environment for themselves. I'm just going to the next one. Again, just a refresher really, just so we're clear on the, whilst we're here talking about Derby City today, we have got other UTCs within Derby and Derbyshire. And at the moment, they're as you can see quite clearly, dotted all around Derby and Derbyshire. So let's go to the next one. This is just to give you a high level, really, overview of the kind of activity that the UTC sees month on month. And as you would expect, around the sort of winter period, November, December, we did see heightened levels of activity going through the UTC, but nothing that wasn't expected. And then we've just tried to give again a high-level overview of the sort of age breakdowns of attendees that we see at the UTC. Next slide, please. When we're talking about UTCs, I think it's only fair that we start to talk about our future around urgent treatment centres and our urgent care response in general, really. And I think what we've tried to do this slide is just give you an indication that we're starting to look at how we look at urgent care within our communities differently, and ultimately making sure we're providing the right level of access to our patients. So there's various different models at the moment. We've got a review of primary care and how their urgent on-the-day access is integrated with UTCs, and how we also look at the population health arena around making sure that we're clear and we've got a good model in place for patients to gain the appropriate access for their condition. it might not be that they need to see a GP. They might not need to see somebody who can, mend bones and things like that. They might just need some general advice. So moving towards a sort of hub model that's truly integrated with other services within the community, will give us that opportunity. So at the moment, this is a piece of work where we're just in development in really early stages, but we thought it'd be a good opportunity just to come and indicate that that's something we'd also like to look at the moment, but in no way, shape or form in a place to make a recommendation on outcomes at the moment. And that's generally where we are with specifically Derby UTC at the moment.
Thank you very much. Any questions for Daniel or Zora? Councillor Froggatt.
Yeah, just to say, I had the privilege of dealing with 111 the other day, because I couldn't get a GP. But what I am hearing from residents is they're ringing 111. 111 are saying you will get a phone call back from your GP the following day. And a lot aren't getting the phone calls. The GPs aren't contacting the patients. So they're back into the regime of ringing the GPs again.
Yeah.
So, is there a rule that the GP has to ring the patient, or do they just leave him, just let the patient keep ringing 111 and hope for a remedy?
Yeah, no, I totally get the perpetual cycle that patients tend to feel themselves in when they're not getting an answer. And I think that's what, through 111, it depends on what time of day they call as well, and is there access to their GP. But 111 have got the also the option to book into services such as UTCs if they're open. I mean, they're usually an 8 to 8 service, so if they can book into those services, they will do. But unfortunately, if they're not open and their triage has given them the indication that they can see the GP the next day, they will be referred back to the GP. I can understand where the patient then comes from when they ring the GP and they can't get in on the day appointment, which is why I think, helpfully, I think with your assistance and with the help of and assistance and feedback from patients, moving towards this kind of model where it might not be that the patient actually needs to see a GP. There's a whole other host of clinicians or professionals that they could see on that day, and just by providing as a more outline of their condition on the day to maybe the GP receptionist or the triage clinician within their GP surgery would then hopefully we would like to hope that they'd direct them to the appropriate person to support them, which might mean pharmacy, might be somebody in nursing therapy, it might not be a GP they need to see.
Oh, thank you.
I think you're going to have to forgive me a little bit, because I think I've got a few questions, and I think it relates back to questions that myself and Councillor Holmes and Councillor Froggatt have all raised before, and we have ongoing concerns. We do understand the general state of play, and so in a moment I want you to tell me a bit more what you mean by the hub model, please. But I think that we have previously expressed a lot of reservations about triage via GP receptionists, which we have addressed to others who have talked to us, Clive Newman specifically, about GB services. I think, so I'm not entirely clear. I suppose my question does relate to this idea of the hub, because I think there's a problem within GP services generally, about access, and I'm just wondering, you're saying this is GP led, but I'm wondering to what extent it's becoming a kind of substitute for people's own GP surgery. There is definitely a runaround. It does feel, and this is not your responsibility, I appreciate that, but we've already expressed to Clive Newman, we've already said it feels a bit like a patient deferral service, not so much a patient referral service, because you can bring your surgery. A member of my own household has done recently, and be told there's no appointments for that day, even there's only 5 to 8. But you, because of the nature of the problem, which is a GP problem, really, it's not a minor head injury, it's ear infection, you're told that you can talk to the triage person. the triage person rings back, then puts them in touch with the GP, who then says that we have to have an appointment at the UTC. Or was it called the Winter Hub? Is it that Winter
Yeah,
Hub? Yeah. So actually, the family member was actually seen that day. So I'm sorry to talk about my own experience here, but it does help us. I think our own experiences help us understand what this is about, because so I am very critical myself of that whole system, where we have quite a lot of staff now, employed on deferring people, but it's like there's a lot of staff involved in deferrals and a lot of phone calls and things to get to see somebody. So I'm a bit critical of that. I think that's more Clive Newman's area than your own areas of responsibility. But in terms of, can you tell us a bit, is this the kind of hub model that what I've just described to you is what happened? Essentially, a GP surgery not seen, somebody who does need to see a GP, they have previously seen a nurse and not got treatment. And one of the problems is also sometimes I think you see a pharmacist, they don't diagnose, they don't even look, they can't physically examine. So eventually you end up seeing 4 professionals before you get the treatment that you actually need. So I am very sceptical about this whole watering down of the system. And Diane wants me to ask my question. Hang on. So let me ask my question, Diane. You're right to point that out. I was rattling on a bit. Excuse me. I'm a bit sceptical, but can you tell me, is this what you mean by it becoming a hub? That experience I've just explained to you is that essentially GPs are referring people there because they can't see them themselves.
So that's what makes me. Dan will, I'm sure, come in with a few things as well, just to help explain the hub model. So this is not developing something in lieu of having general practice access at all. This is actually about enhancing the different access points you've got for, whether you've got a minor illness, injury. It's about making sure appropriate care in the right place, and hopefully improving the access times as well, because we know that obviously can be difficult, whether it's on the day access or needing an appointment with a certain amount of time. But it's a different cohort of patients that we're targeting. But what we're trying to do is get GPs, so general practice, working together with the UTCs, working together with the A&E departments to make sure people go to the right place. So it's.
Now I know there's an awful lot. Please bear with me for a moment, Councillor Froggatt, if you may. We already know that huge amount of staff time and energy now is in this merry-go-round of deferral and referral. So we know this is happening, and we know that people want to work together. I think what's not clear to me at all is you're saying if it's not a substitute for GPs actually offering appointment. I mean, to me, it does feel like that, because somebody wants to see their GP and they are sent to the UTC. I mean, I put it to you that is how GP surgeries are likely to use this. They are likely to use it in a way that means that they don't have to offer as many appointments, I think. I mean, when you say you're not aiming for what cohort, I'm going to ask this question, Councillor Froggatt, then I'm going to let you come in. So what cohort is it that you're aiming for?
So it was some of the things, sorry, the slides have gone down, but there were some really specific conditions where UTCs can see people. Clearly, I mean, I'm not a clinician, so to say that to start with, but there are crossovers between some things that a GP could see someone present with and what someone within a UTC could see someone for. But it's really clear that it's not a deferral service as you're describing, and actually the design of the service is to be around the other way, where a UTC might see a patient and then book them into their general practice, as opposed to the general practice saying we've got no capacity, so go to.
I wish you the very best of luck with that, because quite cynically, having sat here for the last 2 years with the patience of my fellow councillors listening to me bang on about all this, I don't think it's going to work like that. I think you're going to see lots of patients coming to you from GPs who might otherwise see their GPs, because that, I believe, is what's going on in general practice. But I'm going to let Councillor Froggatt come in.
Just to hit on the pharmacist, my brother, who is pensioner, and he went absolutely ape. He came off his holidays with an infection, phoned his GP, wouldn't see him, so he went to his pharmacy that does sees you and will actually administer a prescription. Yeah. It cost him 40 quid. He was not a happy bunny. £20 for the consultation and £20 for a private prescription. I mean, he obliterated Facebook with it, trust me, and he was not happy. But going back to the 111, I rang my GP, which I was in absolute agony because I got pressure, totally deaf in one ear, partially deaf in this ear, trying to talk on a phone with a speaker, and I still was muffled hearing. I had to apologise because I said, I know I'm shouting.
Yeah.
I said, but, you know, the receptionist told me to go to the walking centre. I couldn't stand up. I was that dizzy. So I said, right, I'll do that then. So I rang 111 and then said, I'm going to refer you back to your GP. And at 8 o'clock the next morning, I actually got a phone call from my GP. Couldn't understand a word you were saying. And in the end, they just sent me a text and said, come at 1:30. And I did, and I found out that I'd really got a bad infection and what have you, and on steroids. But that's how it is. It's like Councillor Martin says, it's like they push you back in, they push you straight into 111.
Yeah.
You know, they don't offer you an appointment. I had a text telling me I could not have a same-day appointment. Well, I cannot book an appointment. I've got to ring every day. You know, I can't ring up and say, I'm supposed to be going back in 4 weeks, but I've got to keep ringing up in the morning to book it. It's
Again,
just
probably,
ridiculous.
probably more flat. But I can certainly just expand on some of the hub potential as well. So I think through the conversation we're probably looking at it about, you know, patients attending and wanting to get an outcome. I think we need to look at it from a prevention point of view as well. So when a patient's escalating up into an urgent care need, I think there's an opportunity within the hub model to make sure that from a holistic approach, there's wraparound services that at that point of care that can be referred into to hopefully get an understanding of, you know, are they on the right medications? Have they had a recent health check? And do some of that prevention work earlier on that may just enable them having a different package in the future. And also an opportunity to do a bit of education with patients as well. So there's probably a little bit more time that could be used in just transferring a patient that's had an urgent response, attended the UTC, and now we can hopefully provide a wider holistic approach to their treatment in the future.
I mean, I do think that sounds positive, and just anecdotally, the people I know, including the example I've just given to you, who attended the UTC have had good service. So I would say probably superior service in some ways. So I think there's a feeling that we do have confidence in the UTC. I don't know if you'd agree, Councillor Holmes, on the whole.
Yeah.
Yeah,
I think
I think perhaps I'm not totally sure. I think I think the scepticism, certainly from myself and Councillor Foggett, and possibly from Councillor Holmes, would about how this fits into the overall system, because the overall system is becoming very complicated. I mean, there is a scenario. The scenario I gave, person with an ear infection did manage to get to see same-day appointment twice. I do think seeing a nurse initially was a mistake because the depth of the problem was missed, and therefore a week later it has escalated. And this happens quite a lot when people go, no disrespect to nurses or pharmacists, but I think sometimes, you know, it's not possible to say, well, you can get away with seeing a pharmacist. I can list other conditions where a pharmacist can't look at someone. So on the basis of the description, you might say, well, you can try this. But in 2 weeks later, somebody is going to the GP with a much worse condition. So I'm sort of sceptical. But I think in terms of what the UTC offer, it does sound good. And what you're suggesting is a good idea, you know, good thing to look at. It's just that, you know, traditionally this was what GPs have been offering. And I think we need to, I'd suggest that, so I'm not against this. I do just see it as a way of, I can't see how it's not a way of GP surgeries offloading to you the appointments that they don't want to take. I just can't see how it isn't that, although you do offer a good service. I don't really see how it isn't.
Just made to build on that, because really helpful comments. It's also to remember though that the UTCs have far greater levels of services than a general practice would. So if someone has got a broken bone and need an X-ray, those sorts of things. So actually, it's just important to, yes, there are that overlap I talked about. There are some things that you could see your GP for at your local surgery that you may also be seen at the urgent treatment centre. Take that point. And then there's obviously debate about, where that patient is best seen. But there's a far greater range of services at the UTC. And also, I think, just remembering the conversation we had last time about the A&E performance, UTCs, particularly when they're co-located on the same sites as an A&E, really do help with making sure patients aren't sitting in a busy ED department when actually they can be seen by someone else in a smaller, more appropriate setting as well. So I think that's a real advantage.
That's good, yeah.
I don't think it's the actual GPs themselves. I think it's the GP staff that automatically, there's no appointments, go to walk-in centre. And that is basically their mantra. It's the mantra of the receptionist. They don't even ask you why you need an appointment. They just say, well, if you need to see a doctor, you need to go to the walk-in centre.
Yeah.
And
I
I can totally understand your point, and that's why our team working closely with Clive and his team about the future models of transferring the care, the patient's care safely, and making sure that they do get an answer to their query on the day. So, I think receptionists do a fantastic job. We probably need to call them patient navigators, don't we? Because essentially they're just trying to gather a bit of information to direct you into the most appropriate area for your condition, essentially. So I think that's something we just need to probably take away with Clive and develop forward in the future about how that initial contact turns into getting patients something that they feel is right for their condition.
I agree. I think we probably readily acknowledge that some of our concerns here are perhaps more for Clive than for yourself, because the patient navigators, there is an element that, as soon as you get into that scenario, we're just talking to the phone, over the phone with anyone, never mind a medically trained person, but not a medically trained person, I'm afraid there's a huge level of self-diagnosis then happening on the part of the person presenting. Because it's their articulation which then offers the pathway. But I think that I take your point that the UTC can offer. Basically, there are many people, and we all got people in our wards who are like this. We are confident that they have a sense of what's wrong with them, but it probably isn't what's wrong with them. It's something completely different. So my feeling is at the moment that if you do end up at the UTC, you probably will get the kind of breadth of expertise there that might be needed to actually treat what's actually wrong with you rather than what you imagine's wrong with you, because you simply aren't medically trained. You can't always articulate what's wrong with you when you're not medically trained, and I think that's a gap in the system that is a problem. But so I think this is a very my personal view is that this is a very positive development, and the UTC does offer a good service and often same day service. But I would ask you to take away that this scepticism, certainly from myself, Councillor Broggett, maybe Councillor Holmes, that it will become this sort of backup for GPs who you will be inundated probably. The more this progresses, you may find yourselves inundated with people who can't see their GP that day coming to you, and that's my concern. And I don't know if you've got that's great if you've got the facilities to cope with it.
Yeah, like I say, it's very early on in the review. We need to make sure we're factoring all those points in as we go through before we can make a recommendation about how we look at this forward. But at the moment, the UTC is already there. Primary care as it is currently. I think this relationship between both parties will only improve access for the patients overall anyway, and make sure that they're getting the appropriate support they need.
Can I just ask before we move on? Did you want to come in, Councillor Holmes? Sorry, I didn't catch that. Go on. Yes,
I was just going to ask if you've got any timeline for the review to be completed at all. Are we talking years or months or?
we're hoping within a year.
Within a year.
Within a year, we'll be able to make a judgment on how we move forward.
Can I just sorry, I should have asked at the beginning. Can I ask? Can people detail? I mean, two questions really. Can people? I've still not. Can people contact you directly for an appointment? And secondly, do you have any reflection on the fact that a large amount of your clients or patients are actually in a younger, relatively younger age bracket?
So getting an appointment, you can either walk in or call 111 and they'll do a bookable appointment because they'll want to triage you first. So there's two options there. In terms of generations attending, without spending some time in speaking to those patients, I couldn't comment, but there would definitely be from the data that we saw earlier, probably a drive for, if you go to this place, you're going to get an outcome. So it might just be a generational thing where it's of ease to go to those places rather than it.
Right. Okay. Thank you. Well, are there any more questions or comments on this? No. Well, thank you so much for coming. I think I'm really positive about the service you offer personally. I just think you need to be mindful that you could be inundated. So let's hope you're not, and let's hope even if you are inundated, you can help people, because at the moment people really don't feel that they can often get the help they need without days of persistence. But thank you very much. Thank you. Right, and now we're going to move on to maternity services overview, and this is going to be presented by Chris Viner, who is the Chief Medical Officer for the ICB. And Claire Johnson, you are the Chief Midwife?
Lead midwife.
Okay, thank you.
Yeah.
Over to you then, thank you.
Thank you, Chair. So I'll just briefly give you an overview of what's in the paper, then open discussions if that's okay. So the paper before me, which has been pulled together essentially in the guises of the Local Midwifery and Neonatal Services Board. It's a structure that we have within Derby and Derbyshire, which maintains oversight of all maternity services across both the North Derbyshire area and the Southern Derbyshire area. This structure has been in place for a considerable number of years now, but actually I think it's important to recognise it's picking up some key areas of national interest in terms of developing maternity services, driving quality improvements around maternity services. And these are issues that are being picked up in, say, from 2019 with the long-term plan, which identified that we wanted to see a 50% reduction in stillbirth rates. Then there's the Saving Babies' Lives plan, which came out in 2019, which looked then other key areas of work and focus and attention. More recently, we had CNST work and Ockenden, of course. Ockenden's been a big one, which is a big review of maternity services, pulling out key recommendations, not only for sort of local areas such as Shropshire and Nottinghamshire, but right across the country. There's two Ockenden recommendations which have been asked to be across the country. And then more recently, we had the Kirkup or the East Kent review, which had some key learning as well from practice which was going on down in that area, with the intent, that review identifies some key issues that we need to look at and ensure that we've got good processes around right across the country, including a particular focus, I think, there on behaviours within maternity services. More recently and more pertinent to Derby, I think, is the Healthcare Safety Investigation Branch thematic review maternity services, which started just before Christmas and was published at the beginning of February. It's a very important review, I think, for us locally, and I must say that I must express my thanks to all the families who allowed that review to take place, and for key learning to be identified from the experiences sad experiences that many of those families suffered as they had to contact with alternative services. I think for me, there are a few areas where we're focusing attention at the moment as a local LM&S board, picking up on things like the HSIB review. It's a key area of focus, I think, around postpartum hemorrhage, which is a significant cause of concern and potential very serious condition for pregnant women. There's also an issue, well, not an issue, we're also looking into stillbirth rates as a system. I think it was recognised during the COVID years, not just locally but nationally, that there is a rise in stillbirth rates being seen. We don't know why that rise is occurring at this point in time, but it is reflected in the local figures that we're seeing within the UHDB site. So we have, well, there was an initial review of stillbirths which occurred in January, but unfortunately it was too small a review to be able to come to any firm conclusions. So at the moment we're just trying to put plans together as a system to undertake a larger review of stillbirths, just to make sure we're not missing anything where we could potentially improve services and prevent stillbirths going forward. I think the other key things which I want to mention is that as a system we are looking to where good practice has been delivered in terms of having oversight of quality improvement activities in maternity services. It may surprise people, but actually I think this is a good sign for the health service. The two areas where we've been pointed in the direction of to look for good practice is Shropshire, where we had the initial concerns being raised through Ockenden, and also just not too far across our borders in Nottinghamshire, where they've also had some attention from the Ockenden team. And those two areas are now identified as being good practice areas where we can learn from in terms of maintaining that oversight. So we've had people go into Shropshire and Nottinghamshire to look at what they're doing, look at their services, look at how their governance systems and their programme management to say, okay, so what can we do locally? We're still progressing that work, but I'm hoping over the course of the next 6 months, 12 months, that we'll have a much stronger governance systems going forward and better oversight of our quality improvement activities. I'll leave it there, Chair. No questions.
Thank you very much. Any questions, Councillor Holmes? Councillor Foggett?
Just interested to know, you mentioned that you've been across the borders, Nottinghamshire and all that. Do not all services work to the same perimeters? You know what I mean? Have the same outlook for each department, sort of thing.
Yeah, so there are quality indicators which are at a high level are very similar across the whole of the country. There is variation in terms of how they'll be implemented within the local system. And I think that's one of the things which we need to address. Sometimes that variation is occurring because of structural issues, in terms of how well, and then there's staffing issues and what staff do people have on site and what skills base do they have on site. So there will be variation from one area to another. There are these sort of high level expectations about what forms a good quality service. The issues that we're looking at the moment is to learn, okay, so recognising that there will be variation across between services, recognising that fact, how do we as a local Derbyshire system know that actually our services are safe, know that they're effective, know that actually we're delivering that quality improvement activity that needs to be delivered in order to best improve the quality of services for pregnant women.
I'll just add to that as well. I think that building on what Chris said and what you've asked, particularly related to the Ockenden assessments that we've referenced in the paper, a lot of that came down to evidence and proving what we're doing, and what Chris has talked about, those areas are doing it better than we are locally. So we want to know how they're providing that evidence for us to get that oversight and assurance. So by visiting there, we're hoping that we can then use their
Ideas. Pinch their ideas.
Because I have actually read the report twice actually, so quite a detailed report, which is great. It's very well written, and thank you for all the references at the end. I have to say I haven't had time to go through all the LinkedIn references. If it were at a different time in the year, I might have read around this a little bit more. But I think there are, I mean, overall in the stats and in the points you're making in here, whilst you obviously don't feel any cause for alarm at what's happening in Derby in the maternity services, the statistics suggest that there are real areas for concern. I mean, you're not meeting the Ockenden recommendations in many cases, in many areas. Derby seems to fare not as well as the Chesterfield hospital. I mean, we know that it's all part of the same system here, but our job is to focus on Derby, much as we care about Chesterfield as a fellow city, etc. But so there are some issues that I wanted to raise with you and highlight, because I'm sure you are working on these and are concerned about them, but they're not totally reassuring. I mean, there's a thing in 2.3 which isn't about safety, which I'll keep doing that up at the end. I mean, clearly staffing is a problem. I mean, I know midwives, that's the problem. I do know them. They're generally overworked, terribly unhappy at work because they are people who go into it for a vocation, and the ones I know don't generally feel. Everyone moans at a counsellor, but I think the concerns are genuine, that they don't feel that they can fulfil their vocation because of the stresses and strains within the system and the understaffing. I think understaffing is key. There are different methods. There are obviously different views on how the system is being operated and what practices are being approved or not. But I think fundamentally the lack of staffing is an issue, and obviously it's an issue in Derby, because you say in 2.4 that you've actually the home birth service has been suspended until 2023. So can you just tell us a little bit about your workforce numbers, because I do know somebody who actually happened to work at the QMC in the maternity services, and I know often they only have 2/3 of the amount of midwives working on a shift that when the 2/3 of the amount that they maybe ought to have. Often that kind of figure, that's not an exact figure. Can you tell us what the staffing shortages are like at the Royal Derby?
So there are staffing issues, and it's a national problem because there aren't the midwives to pull into the posts. So funding's available for staffing, but it's the actual people that aren't available to take those posts. The reason it's suspended until September is because it's felt that by that point staffing at Derby will improve, because there'll be another lot of newly qualified midwives. They come into practice in September. The way that the training goes, because it's lined up with universities now, it tends to be an annual thing. They've also recruited 18 internationally trained midwives, but they obviously need to take time to train and adapt to working within this country and our guidelines. So again, that's being put into the mix, but won't be addressed till September. Currently, UHDB are running a vacancy rate of approximately 38 whole-time equivalents.
Sorry, what was that?
38 whole-time equivalents. So that's 38
members of
38
staff. Yeah. How does that sort of match to the overall number then? I mean, what does 38 out of?
So I don't know in percentages what that represents.
Or what's your staffing level overall?
I think it's
Have you got 300 members of staff, or 100? Or?
Yeah, about 300.
Oh, really?
So,
Oh,
yeah,
well,
there is.
that's a good
Yeah.
guess. So you've got 38 vacancies.
roughly, yeah, approximately, and obviously that varies, but at the last time that it was reported back to us, that's what it was, which was just earlier in the year. Gaps are filled through enhanced bank rates, so midwives have been picking up extra shifts or coming into work on the bank from other areas to cover gaps, so they have managed to cover shifts in that way. The reason, again, that's partly that home birth service is suspended is because the community midwifery staff are then used to work within the acute unit when they're on call. So what would traditionally have happened is that they would have come into the unit, they would have for a night shift, and then they would have gone out to a home birth. If one occurred, 2 midwives would go out at a time. So at the minute that's suspended so that those midwives can work totally in the acute unit overnight to increase numbers and obviously make it safe. Maternity service, that's at that point.
And do you review locally why midwives are leaving? Because that's one of the big problems, isn't it? Is that staff are leaving. I think we have a I'm not naive. We do have a general sense of the pressures in the NHS. We've been sitting here for the last 2 years hearing about this, but I just wonder if it's, you know, if there's anything you do locally that can really take into account. Because there is a lot of talk in here about the importance of engaging with women's choices, and I think part of that is very much usually a midwife agenda, if not the institution's agenda, is usually very much the midwife's agenda, is working with the women and supporting them in what they want. Obviously, or supporting them through whatever happens, I suppose. I mean, you know, as a midwife yourself, do you feel is there more you could do to kind of make that climate? Because I noticed later on as well, you have some training on the culture in the leadership culture is happening as well. I'm not just casting any aspersions but you know, is there more that it could do to stop this hemorrhaging of staff?
I think there's,
because it isn't just money, is it?
No,
it is money. It is money, but it's not just money.
It's multifactorial. I think the pressures over the 2 years have had an impact on staff. So staff that were reaching retirement, who may have worked longer, decided to go. So at the earliest stage of available retirement age, they would probably have left, whereas a few years ago, midwives would probably have worked longer. So I think that's part of it. It is some of the recruitment as well, getting younger midwives in and getting midwives to stay, because it is a tough job. So there is something there. So what the what the hospitals have done is put in recruitment and retention midwives, and more money's being put into that to fund those as a longer term objective. So it's more about staff wellbeing. It's about recognising where staff are struggling and what can be put in to help those. And there are various staff wellbeing initiatives that are being addressed and brought into the trusts to support staff that are finding it difficult for whatever reason. At UHDB, there has been a change of senior leadership, and I think that potentially could have had an effect as well, that they've now got new senior leaders. They've got a new deputy head of midwifery in post. She's only just come into post in the last few months. So I think there has been change there as well, and sometimes that affects the stability of the service.
Yeah.
Although I do think it's important to point out that the change which we've seen in recent months, it's changed for the better, it's changed for the good.
Yeah,
so the information we're getting back, what the staff are saying is actually they prefer the current leadership to, they feel they've got more confidence in the current leadership than they may have had at various points in the past. I think at the heart of the issue, though, is this issue about the number of staff we have and our ability. So, whilst we've got relatively low, when we've got vacancy rates and high vacancy rates, that means that the pressure on the people who are there is greater.
Yeah.
And it's harder work. And it's tougher, and they don't have that time to develop their skills, to keep their skills up to date. And I'm not saying that that's linked to the outcomes at all, because we don't have that indication. But it means that actually for those individuals, it feels like a much harder job, because they just don't have that space, that capacity to do the job that they wanted to be honest, when they came into the service. So I think that the key for our future in these services is addressing that staffing gap, but it is difficult, and it's difficult because it's not just a local problem; it is a national problem in terms of total number of midwifery staff available who are appropriately trained for these services. So, and that's why we're looking, to recruit from abroad in certain locally and to sit and say, well, can we bring new people into the system to help essentially not only fill the rotas but make life better for the staff who are working in those services and make life better for the patients that we're trying to serve. And until we do that, we're going to have issues where there are certain elements of the service which we may not be able to have fully
It's a
open.
downward spiral, isn't it? Just
So we've
one
got to turn
thing
it around.
accentuates another. Yeah, Councillor Fogg.
Yeah, just going back to the incentives. I mean, we all know babies turn up any time, and a lot of the hours worked are antisocial the nights. Is there any incentives for free parking on site, especially at the city? If you're a midwife and you're working nights and that, you don't want to come out in a dark morning after a long shift into a dark area or wait for a taxi, or surely some incentive of a free parking spot during the evening at night.
I think that's a trust policy. I'm
And
not,
the
And
local one,
Yeah,
that's the trouble.
yeah,
but working nights, it is
Yeah,
Yeah, but there's a lot of nurses working
Yeah.
nights, they'll all want one, that's what I'm saying.
yeah, it is a trust policy. So it's difficult to bring in for one staff group.
Councillor Holmes.
Yeah, I was just going to ask about the training actually, because I mean, my nursing training was in the 80s, and at the time, correct me if I'm wrong, was it that you had to do your 3 years nursing training and then was it another 2 years?
18 months.
Is it the same kind of situation, or are midwives just trained to be midwives now?
Yeah, there was a drive to, well, it did go back to just being midwifery training. So it was, you chose to be an adult midwife or an adult nurse or a midwife, got the words right. So that changed. What they're going back to now is they are starting to offer the enhanced training for nurses. So the UHDB and Chesterfield have both got places for adult nurses on the upskilling for the midwifery training, which I think, I'm not sure if the new one is 18 months or 2 years, but they are bringing that back in. So both trusts have commission places on that, and those staff are currently being trained. But again, it's a longer term objective because they've still got to go through that training.
So is that, is there anything relating to the training that is putting people off? Is it too long? Is it?
Yeah. I mean, what's been said is because it's now university based, then you don't get the bursary.
Is that a good idea? I didn't agree with it when it came in at all, and I'm not sure it's the best idea.
Yeah, it can detract, I think, for people with families to go into it because they're not getting a bursary. So you've got to be able to afford to go to university to do the training. So obviously you're doing a full-time job whilst training and technically paying for your training. That has been raised, but that's the way that it went, unfortunately.
Yeah, I think the key is to find out the obstacles and try and remove them. See why people are being put off, because again, back in the 80s, waiting lists 2 years for nurses and midwives. It just, something has gone wrong, really.
I think it did start to change when you stopped being paid to train, which basically when I trained, you were paid, you got to.
Yeah. Yeah, it's the university thing, I think. So.
Yeah. Because I mean, you do need a lot of bottle. You really do. I mean, nursing as a whole is a really demanding job, isn't it?
No, look at me, I've not got the backbone in my body.
Yeah, but I do think midwives have, you know, I haven't been there as a midwife, but I have been there twice, you know, as a
The other end.
if you like. And they, I had the same midwife both time, and God, she's got loads of bottle. She's a fantastic person. So I think there's a kind of courage really to be more formal. I think it's a job that requires all those skills and loads of courage, and then loads of empathy and endurance, and it requires so many skills. I know a lot of medical jobs do, but you're really, I mean, basically you're on the front line, aren't you? It's not, I mean, it really is intense. Maybe that's just the experience. I think it's very intense for the midwives, and so they do have my enormous admiration and empathy. And I agree with Councillor Holmes that I mean, anything the local trust can do. I do also agree with Councillor Foggett. It may seem like a small point, but for all the staff who've been on nights, you know, you're coming out and you're fumbling around looking for how to, but I mean, that's really not what you need when you've been on nights and you're coming out, you're fumbling around looking for change or card, or I mean, you just want to get in a car or get on the bus or get on the taxi and go home. I suppose if you do the latter, it's not so difficult, you've got to wait. So, I mean, any small thing, I think we would recommend that would help, but I think there probably are broader issues, national issues that are probably against and are not what we can't influence. Do you mind? I think we can express our admiration for midwives collectively, can we? And say, please do everything you can to keep warm, because they're fantastic people. But I do have another few points about the presentation, if that's okay. So 2.5, you do talk about the stillbirth rates and the neonatal death rates. And obviously, I mean, come on to this in a minute. You don't talk about maternal death rates. I mean, death rates are not the only thing that interests us. We know that overall these figures are relatively still very low compared to the number of births, so that needs to be contextualised in that way, doesn't it?
Yeah.
But on the other hand, what we do know from your figures here is that Derby is well above the national average for stillbirth. And I know you talk about this as being an issue and a problem that you are addressing or trying to address, and trying to find out why this is the case. I don't know if it is concerning. You don't break it down very much though, because in the news today, there are articles about the differences between, say, black women in maternity services, or the experience of giving birth, where they're 4 times more likely than a white woman to die in 6 weeks of giving birth, and Asian women 1.8 times more likely, and obviously 2.5 times more likely if you're poorer compared to richer areas. So I'm not criticising the report because it's very detailed. I know you've got a lot of things, but I don't know if you want to try and tell us a bit more about what you're doing, what factors are causing this stillbirth rate to be so high or relatively high in Derby, and also what any of the points you can make about these are the factors of maternal deaths.
I think the short answer, Chair, is that at this point in time, we don't know what's causing the rise that we're seeing in stillbirths. It is an issue, for us. It is a matter of concern, and we want to look into what's actually happening there. As I say, we had an initial review which was done with the UHDB in January this year, which it was felt to be too small a review to be able to identify any consistent themes in those deaths that had occurred, and which were reviewed at that time. So we are looking at trying to undertake a bigger review, possibly using a different sort of different structure, a different approach as well, to review deaths and see if that actually we can identify a common cause for those stillbirths. So the short answer is, I won't give you an answer as to why we're seeing that rise. What I can tell you is that it is an issue that has been seen across the country over the course of COVID. You talk about the inequalities agenda. Actually, if you look at,
But can I just interrupt? But the reason I'm raising it, I know it's gone affects nationally, but we are above average according to your statistics. So I think that still needs to be borne in mind.
Yeah.
But sorry, carry on.
I mean, you're right to point out the issues around inequalities, and I'm aware of the reports that have been in the national news today. What we can see in terms of where families come from, where those deficits occur, there are certain there are communities where we know that there are socioeconomic pressures across Derbyshire, and we see more of the deaths occurring in those areas compared to maybe some of the better.
You see more stillbirths from people. You're seeing more stillbirths, sorry, from people.
Just double check with you, but I think that's the case in terms of what I've seen them plotted out on the map. But I think so. That's one of the factors, but it recognises the similar. That again, that is reflecting a pattern which we see across the country. I think the key question for us at the moment is there anything that we can do where we can intervene to try earlier to try and prevent any future stillbirths? And but we don't have an answer.
So so obviously you probably don't want to answer this, but if I may put it anyway, because it's hypothesizing, and obviously this is a very serious issue. But I mean, is it that because we know that where did I see this today? It's probably on one of your reports. It's maybe on your report actually, Robin. That inequality in the city is greater than health inequality is greater, a bit larger than it is in the county. So you see more intense. We do have some of the most deprived areas, poor areas, impoverished and deprived areas in the city, in the whole country. So is it that intense? Is that intensity, that concentration of quite intense levels of poverty, which are likely, which could, I mean, let's put it hypothetically, which could have an impact on this stillbirth rate? Is that plausible?
Yes, it is, Chair. And I think that's one of the reasons why we're so keen as an ICB to work with the local authority to help tackle things like poverty issues that we see around the city and around other parts of Derbyshire. It's not just affecting maternity services, it affects health outcomes for people right across their life course, whether they're young or whether they're old. But it could well be a significant factor in terms of our maternity services and maternity outcomes.
Ethnic background is always reported on with any stillbirth or neonatal deaths. So that is one thing that they can look at. And in the information we've had so far, that didn't seem to be but that's why I think they're going into the deeper dive and do it using more factors to
so that's interesting then. I mean, I raised that in relation to the report today about nationally but that's in relation to maternal deaths, which is obviously a different thing, isn't it?
Yeah.
So I'm not trying to confuse things, but that is interesting. So it would be interesting to know, perhaps at a future meeting, when if you could come back and tell us what the investigations are telling you. Because are you suggesting do you have a sense that it is the kind of experience of the pregnancy rather than the experience of trying to give birth at the actual hospital, or do you just simply don't know? You just couldn't speculate.
they would particularly.
Yeah, we've got no indication, no direct indication that they're directly related to the quality of the services. And we've had a number of people go in and review. So we've had HSIP who's been in to UHDB, review their services. They did identify quality issues in their thematic review. They did not identify any immediate pressing safety concerns when they went to, and I think that's important for us to recognise. We've had reviews from the national support team around maternity services go into UHDB, and their findings are very similar. It's in actually no immediate pressing concerns around safety within our UHDB maternity services.
That is
However,
reassuring, but if I could come back on that, I know you do say that in the report, but there's a big but after that, which is that you are not compliant with these Ockenden recommendations.
Yeah.
And in relation to the other category in 2.8, you've got various categories where you're trying to.
Lives.
Yeah, that's right.
Yeah.
That one. It says that neither the Chesterfield nor hospital nor Derby hospital actually meets the safety standard.
That's CNST. So
Yeah. So that is concerning. I'm not trying to be overcritical, but that it is our job to raise these concerns and to ask you, what does that mean?
When you're right to raise those concerns, Chair. They're concerns that we have as an LMS board. We want to see that improvement. We want to see delivery on these key issues going forward. Some of them will take a significant period of time, particularly where they relate to staffing related issues. So, but what I can say is, in terms of immediate safety concerns, we're not having concerns raised by people who've gone in and reviewing services, independent teams going in and reviewing services from outside UHDB. That's not to say there is not considerable work to do to improve the overall quality of our services for pregnant women across Derby and Derby City and Derbyshire.
Comment? You would come in at all? Just bear with me a couple more points then, if that's all right. So on I don't particularly want to keep focusing on there's so much to this about the quality of the experience, but honestly, it's just it's an amazing thing. But obviously, in the end, it's not an illness for women, but it is a bit physiological of the body, event of the body, and women die, and babies die, and I know that's something you're very aware of. Do you have any stats? But you must have stats for maternal deaths. Could you? You haven't got them in the report.
Yeah.
Could you? Is there anything you can say broadly about that to us at the moment? Because we don't have any sense of it.
We have the three that were investigated in the HSIB report. So they occurred between 2020 and 2021. So we haven't had any more recently than that.
Are the death rates relatively quite low then?
Yeah.
I mean, that is what we'd expect. I
think it's one of those things that sometimes you won't see one, thankfully, for a long time, and then they did just have a few quite close together at UHDB, but again they were thoroughly investigated within the report, but they're not outliers for that if you look nationally.
Right.
However, what I would say, Chair, is that clearly we've had the thematic review done by the Healthcare Safety Investigation Branch. We have identified learning from those incidents. We have identified quality improvement things that we can do to try and improve the safety for future women going through those services. And our focus is now on fixing what we know we can fix, to ensure that actually future women don't go through the same sort of scenario, don't face the same sort of scenario, and potentially the serious outcomes.
Yeah. Okay. Any more comments from over here? I do have one final point, which you probably don't want to hear, but there you go. 2.3. I don't agree with referencing pregnant women as pregnant people. I've made this view. I do think if you want to start employing women, often usually women, although men can be midwives and that's fine, as midwives, they come in to serve women, to be with women, to help women at the most female bodily experience time in their whole lives. And I know why you're using that phrase. So you don't need to explain it to me. I know where it's coming from. And I've said this before in front of Robin. I'm sorry, but I particularly object to that. These are pregnant women. And obviously there may be a couple of people with female female bodies who identify as men. But I mean, I could ask you how many men you've had in the hospital giving birth, but I don't think you have that stat.
We have got people who identify as no, but are obviously female genetically. The reason, and we have had those give birth. The reason that it's referenced as pregnant people in here is because the Derbyshire Maternity and Neonatal Voices, who represent service users who we work with quite closely to hear service user voices, do ask for that terminology to be used. So that's where it's come from. It's come from local service users.
Well, I think that there's disproportionate voices being heard, frankly, and I'm a voice that is questioning and challenging that quite openly. I think that whilst clearly services for people who identify as male, men giving birth, if you like, need to be recognised, and that particular scenario needs to be understood and treated linguistically appropriately. I think to then turn that into a generic scenario where we can't reference the fact that it's actually women with female biological bodies giving birth is quite destructive for some of the aims that you want to, because you have to talk in the language that they will be referring to themselves as. And so if you're bothered about deprived women, you're bothered about people not engaging in healthcare, I think my own view is that you need to call females who are pregnant women. I don't know if anybody else wants to come.
Well, I do. I certainly agree. I feel insulted.
Indeed.
Being a pregnant person or a pregnant people, or I was a pregnant woman.
Okay, so I'm afraid there is one tiny minority with a very strong voice, but the big majority is now voicing a different point of view. So I hope you will come back and tell us a bit more another time, please, about your about what you're discovering on the stillbirth scenario. That would be very grateful, thank you. And I hope you will not report to us with the phrase pregnant people, and if you do, we will be making, if I was the chair, we will be making a strong recommendation that ceases. So, but there's no other comments over here. Thank you very much for your time this evening. It's been really interesting. Thank you.
Thank you.
Okay then, moving on to Robin Lewis, who we all know very well, Director of Public Health, who is going to talk to us about the Derby and Derbyshire Integrated Care Strategy.
Thank you. So just to start with the context setting for this. So this is the development of the Integrated Care Strategy, which is for the health and safety for Derby and Derbyshire. So Joined Up Care Derbyshire, as was known, and is now developing into the integrated care part. It's just that. So I think it's helpful at the bottom with the logos at the bottom, just to indicate who's actually involved in this one. It is the NHS in the form of the ICB colleagues who are in the room, also the providers, but also we've got Voluntary Sector Alliance within that, and us here from the City Council and also from the County Council as well. So
Are the GP services included in this?
there are various different strategies and documents around, and what this is about is about health, social care, public health working together across that footprint. But just bearing in mind that we also need to incorporate all of the other strategies as well. Next one. So this is just really a summary of how the document has been developed. So it has been developed, as I said, through all of those organisations, and we here have been very involved as well in that production, both through social care directors and through public health as well. And also our voluntary sector partners in the city as well have been linked into the development of this. And there's also a communications and engagement group through which Health Watch have been engaged as well, looking at how best to engage. There's a timeline there as to where things have been, and the document that's been circulated is the draft strategy that went to the Integrated Care Partnership in February. We've actually got the next meeting tomorrow, so we'll be reviewing the final version tomorrow. Next slide. I think this is just, adding to that context. So, yes, we've got the integrated care strategy, we've got the health and wellbeing board strategies, we've got city and county ones of those. We've got various other plans, national guidance, the old joined up care Derbyshire plans as well that were there, that there's still some things that we need to carry forward, and the anchor work as well. And within all of that, as we talked about previously, the incredibly challenging environment, both from a financial funding for services perspective, but from a staffing perspective, and the need and the demand on services as well. And we know that over the past few years that there has been an increasing in health need over this period of time. So the plan is that by bringing us all together and coordinating those strategies and working in a bit more coherent way, that we can come to a better outcome for people who are using those services. The next slide, please. So these are the 3 outcome areas that sit within the strategy, and they do fit with the Health and Wellbeing Board strategy areas as well. So thinking about starting well, thinking about pregnancy, children, and that development early in life. Also thinking through education as well when we think through that. Thinking about our general working life, how we live a healthy life, and importantly, how can be well and achieve and succeed. And then through to aging well and dying well, and thinking about how do we make sure that latter period of life is as independent and as healthy and fulfilling as it can be. And then we come to the point of death that is a good death is reached as much as possible.
Yeah, we know what you mean. It's
So
end of life.
end of life. I think so. For those of us that have been involved in the final period of people's lives, I think you can see when that is done well, and when you feel that everything is in place that needs to be in place for this. So these are the next slide. Sorry, I've moved on. I haven't. So these are the system-wide population indicators that we're looking at within the strategy, and these have been very much developed through the public health teams and our reviewing of what drives poor health within the population, thinking about particularly respiratory, cardiovascular disease, cancer, those areas, and what we need to actually change in order to improve the health of the population. So I don't think there'll be any surprise to you from those areas that are noted on there. And as mentioned before, we have aligned those as well with the areas for the Health and Wellbeing Board. And we're currently in redeveloping the Health and Wellbeing strategy for the city. What we're looking at doing is aligning that along with the Derby City Place and the Health Inequalities Partnership as well, and considering all of these indicators within that. The next slide, please. So what we're aiming to do within the Integrated Care Partnership is very much think towards the earlier end of pathways, to think about prevention, early intervention, to think about reducing health inequalities, and to develop that care around the individual as well. And importantly, that last point, I suppose the first 3 are really about the outcomes for people. That final point is really about how we all work together and how we make the system more coherent. Next slide, please. So it was felt that it was important that we have what's described as key areas of focus. So these are not priorities or single areas of work, but these are the areas that we have agreed together that we need to pull together and work together and focus on through this strategy. And you'll see that they are under those 3 stages of life: the start well, stay well, and age well and die well. And for the start well area, this was decided through the Children and Young People's Board, and they felt that school readiness was a really good indicator to look at for children and young people, particularly focusing both the educational development, but the physical development, language development, speech and language development, all of those areas, so that people are ready, the children are ready for school. From a stay well perspective, and that's thinking about working age adults generally, we're thinking about, as mentioned, those main causes of ill health and health inequality. So thinking about circulatory disease, respiratory disease and cancer. And actually, when you look at those 3 conditions, the actions you can take to reduce the risk of those are actually very similar things that you can do. And then thinking about the aging well and dying well, that's very much focused on supporting individuals to be independent and how services can work together around people and keep people at home as much as possible. And that's being led through the place partnerships. So thinking about the how and the enablers, and this is it's quite a large structure and system to pull together, and how can we ensure that this works. So there's lots of considerations around how the governance within the system works and how we can communicate the strategy to everybody working within the system. I think sometimes for people actually on the front line, it can be quite difficult to see what we're actually aiming to achieve overall. And there's a list there of those enabling functions and services that are included. You'll see that we've got the voluntary sector in there. We've also got population health management, which is looking very much at the data, the needs of the population, and how we can think on a population basis, how we can improve health as opposed to on an individual basis. So that's within there as well, looking at commissioning and how we can commission together or align our commissioning to be more effective. To the next. So there's been a development around engagement, and there's a communication and engagement group, which, as I mentioned before, Health Watch have been included in. So there's been various programmes so far to develop this conversation about the development of the strategy. And it is very much around those early stages, around this is what we're thinking, what are your thoughts, what's missing. And then for the next steps, as mentioned at the bottom there, it's about how do we engage in the delivery of this strategy and what this is actually going to look like on the ground. So that will include conversations with communities as well as with Health Watch and the voluntary sector as well. So next slide. So part of this, as always, is some of this work is already ongoing. We know that some work has already started. It's not that we're throwing away the previous strategies. We need to build on what's already been done. But also important that we're not just rehashing old things. We need this to be a different way of working. We need to look differently at the population so that we can ensure that prevention and early intervention is absolutely embedded in what we do. So there's work on around what does this look like, how can it be delivered, and how can we be really clear about the expectations. Part of that is including looking at what the resource is in this strategy delivery as well. There's been a decision that the integrated place executive is going to oversee the strategy. What we have is a city and a county place board, and they feed into the integrated place executive, which overarches the both of them and focuses on how we can develop that work together at place across the system. And they're also looking at an evaluation framework to consider the effectiveness of this and to ensure that we're actually looking at how the strategy is working and how we're moving and developing it over time. Next slide, please. So when we're thinking about impacts from the strategy, really enhancing what we have developed over the past few years, particularly around COVID and our collaboration and collective working, and how do we build on that and embed that? How do we ensure that all of those different factors within the system that can help us to deliver this are joined up? We've got those key areas of focus agreed, and we're developing plans as to how we're going to tackle those. And also we're working together on the engagement around this strategy, and we were only having conversations, I think it was last week, around how do we ensure that the engagement in the city is joined up with the rest of the engagement activities in the city. So we've got the Health Inequalities Partnership, we've got all of the other work that the council is doing as far as engaging with the population, and how do we ensure that we embed this engagement within all those other structures and processes that we have. So that's the draft strategy that went to the last integrated care partnership was attached to the papers. We've got the final meeting tomorrow to review the strategy. So very happy I will be there at that meeting if there's anything that you want me to take forward as comments or feedback.
Thank you, Robin. Any comments? Yeah. Councillor Foggett?
No, just that looking at the health and that, the well-being of the children and that, 0 to 5 and what have you. And Derby City Council is involved in all this. How far is the council's involvement, as in when the children get to teenagers, we know there is nothing for teenagers to do, so therefore they start congregating, and this is when they go down that slippery slope into drugs and God knows what. Is there anything on the table that is going to, you know, with the voluntary organisations and that, with help from the council, to put in clubs or something like that, you know, to try and capture that age group?
I think that probably something that sits with us here as opposed to with the ICP, isn't it? And it fits within various different aspects of the work that's ongoing, and it is very much recognised as an issue around meaningful engagement effectively, isn't it? It's about how to keep young people
Interested in something.
yeah, help them to be enjoying their lives in a positive and purposeful way, and that is very much something that we strive for, as opposed to this work which is sitting with the NHS. Is that something that needs to, where that spreads over various different departments in the council? Is that something that we need to talk about?
I mean, the thing is, you say, you know, it does come because they're on motorbikes, on e-scooters, so ergo there will be accidents, there will be, broken bones and things like this. And we're not talking just teenagers. They do stop from about the age of 10, even younger, and to try and capture, just for something to do for them. Plus, there is nothing in Derby at all, really.
I think that's part of the general strategy for the development of the city, isn't it?
Yeah.
Around the vibrancy, around all of the leisure options, all of those other things.
It also comes on to health and positivity.
Yes, I mean, I think from a health perspective, there are, you know, as a young person, when you're at secondary school age, if you haven't got a long-term condition, there's kind of limited contact with health services, isn't there? I'm just trying to think through that. The main context really for those young people is their schools and their out of school activities, isn't it? Let me take that away, because I think that's much more of a council conversation around what's happening within the different departments. And I'm aware of some of the work that we're doing through school nurses, and we're also establishing the the drugs partnership, the city and county drugs partnership as well. And part of that work is also around young people and that side of things.
Yeah.
So I think there's lots of different bits.
Talking to the youth worker in my ward, there are only certain children that can get there. You know what I mean? Who are allowed to go into this club thing. Yeah, you really have to be damaged. I hate to use that word, but damaged to be able to access. Whereas the mainstream of the kids aren't damaged as such, but probably will be in the long run if nothing is, there's no intervention. Yeah, it seems to be for a selected few.
Yeah, let me take that one away. I wonder if that's something we can.
I may intervene on that. Somebody put in an amendment to the council budget last year to stop us losing even more youth workers from the council, but I understand that funding wasn't spent on that. It was given to the outside bodies, youth bodies anyway. So this has been addressed by me, Robin, because I do agree with Councillor Froggatt that it's a problem with budgets, isn't it? And also how far a council should extend its services. I mean, the council can't resolve, can't do every function and provide things for everybody. But I think the problem is when you're only helping those who are already, there's a whole set of people who would really flourish if they had a little bit of help. There's some people who need intensive help. They're the ones who get all the help. There are people who don't really need any help anyway because they're getting so many advantages anyway. They are flourishing. And by not focusing on that group who need a little bit of support to really flourish, and I think it's my own view is there's a big loss to our society. And that was my view in putting the amendment to that last year. Anyway, but thank you for looking into it further.
Yeah, I will do that.
Councillor Holmes, I'm going to raise one quick point. Do you want to come in first?
I was just going to say, so on the draft, so it says prioritise prevention and early intervention to avoid ill health and improve outcomes. So as we've all discussed, nobody can get into a GP. Why do we always keep going back to that? So although the words are there, how is that actually going to be any kind of implemented when, you know, we've heard about all the problems obviously with GPs and so is anybody doing anything about sorting out the problem that nobody can get a GP's appointment? Basically, is that, I know that's obviously your aim because it's written there, but how is that going to be implemented? Sorry.
No, exactly. And when we talk about prevention and early intervention, it is the range of prevention and early intervention. So part of that will be primary care services, part of it will be stop smoking services, part of it will be encouraging people to be physically active. You know, it is the breadth of that. But obviously, I mean, just like we had conversations before about access to dentists, didn't we? It's exactly the same. Mm-hmm. You need to be able to access that advice and input, don't you? We are in a really challenging position nationally as far as GP capacity numbers, aren't we? And I say this from the position of somebody who used to be a GP and left to do something else, and you know, that's not uncommon, is it? You know, as we've seen around people finding their work really challenging, and the busier the work gets, as we discussed, the heavier the burden, the more it encourages people to leave and to move on and to do things. I think we have to be encouraging about that recruitment, but we also have to be realistic that there is no quick fix to everyone. And part of what we need to do is consider what aspects of our health can be managed elsewhere. So there's been some conversations that I've certainly had around detecting people with high blood pressure within the population, and there's some work ongoing to do that. We know there's many people with walking around with high blood pressure who don't know that they've got it, but actually thinking about, well, if we find all of these people, how on earth will they get into their reviews in general practice? It will be a huge ask for general practice to do that. And actually, is there another way? Can we utilise pharmacists' skills with blood pressure checks and with medication? Can we utilise lifestyle services and advice around activity and weight loss to actually reduce blood pressure? Are there other things that we can do? Historically, we would have just wanted to put more GPs on the ground, but we have to be realistic that isn't going to happen, don't we? What else?
But it doesn't. I don't know. It needs to happen, but I'm just thinking in terms of, I don't know. You've got pain, and you're like, oh, it's not important enough to go to bother going through all the rigmarole of trying to get a GP.
Yeah.
So I went, well, it'll go off, and of course that pain is then something more serious, and it's too late. There's so many times that I've done exactly the same. Thought, oh my God, I can't be bothered to get up at 8 o'clock in the morning to press redial. So, look, like I say, it says prioritise prevention and early intervention, but that aspect of it is really stopping, I would imagine, that.
If I could come in, Councillor Holmes, I think it kind of feeds into the kind of point that I was going to make, Robin, which isn't meant to be critical. It's just an observation, really, that there is, because I mean, Andy Burnham was talking about the need to integrate health and social care in about 13 and 14, and I thought, oh yes, that is a great idea. It really is the answer. And of course, now this is what's happening, and I have seen, I don't know how many reports on this process now. And I have read them. I read them all, and I sat in the Health and Wellbeing Board, and then we hear about community engagement over this. And I have to say that I do not think, and maybe there may be no other way of doing this, because to really be able to engage people effectively, because it's about these huge institutional structures trying to work together. And what I suggest, if I may, is that all of that is mainly going to resonate with and for the professionals. It's not going to resonate with the public. I mean, you've already got the ICB, you've got the JUCD, you've got the ICP, you've got the IPE, which I have to confess, that latter one, I think I have and I don't know what it is. And you've got, I mean, when we were at the last Health and Wellbeing Board, it was like this whizzo series of charts, and it did actually make me laugh, because it's almost like and I think so. Basically, I'm not being dismissive. I just think that it's very hard if you're not part of the managerial systems of the health systems to really get any grasp on this. And I totally agree with what Councillor Holmes is saying, is that this is probably no doubt this is a very important, probably very beneficial development. But if you want to engage the people over this, I mean, you may engage a few people who've been on Health Watch almost on a quasi-professional basis for the last 20 years. You're not going to engage many other people, because it will be totally meaningless to them. I confess, I don't know what the integrated place executive is. I don't know how that relates to the ICP, and how any of that relates to the JUCD. Well, I do know actually about the JUCD and the ICB. And then you've got ICS as well being used. So the point I'm making really is agreeing with Councillor Holmes. We are sitting here and we know that people cannot get to see their GP, and that there is this kind of constant, now this the way of managing that is this, as we've talked about already, so we don't really go over, but this proliferation of phone here, phone there, which, you know, for those with patience and persistence and belief in their own needs, that is very, very alienating to the people that this is partly aiming to engage. It's extremely alienating. So there's a sense that there's this structural thing going on, and it's good that everybody's working together. And the other thing I keep hearing, and this is not a criticism of numism by any means, Robin, by any means, is that when you say, well, what does this mean? People say, well, we're working together. I mean, working together is not an end in itself. It may be a managerial strategy, you know, and a system strategy, which people believe will deliver better outcomes in the end. But in and of itself, it's just another management structure and strategy. And so now when people say to me, we're working together, because I've heard it so many times over the last 18 months, I say, well, what are you working together to achieve, and what are you achieving? And that's not meant to be critical, but it is becoming a mantra. Do you see what I mean?
Yes,
I almost have the answer. And I know that this isn't a criticism of you, it's just an observation on this process where I'm very happy to accept this report as it is. I don't particularly feel able, it looks fine, it looks like a good strategy. You're concerned about many things. The only thing I would say is that I think you may as well say it, that poverty is the health issue. It's a bit euphemistic around that. And also the other thing I would say is that there's no reference here to food, which is a key factor in health, is food. But putting that to one side, you know, overall it looks fine. I would just say that I think this whole thing needs to be not taken with a pinch of salt, but viewed in context as to what it's really about and who it really applies to, because we all know that we all know what is worrying people. And the overwhelming thing is that access to the GP. Everything beyond that, you know, UTC does work well. If you get to the hospital, it's generally pretty good service. But I think until we get that, I'm not trying to make any kind of political point here whatsoever. I mean, I just think it's true for everybody. It's not that people are naively attached to their GPs and don't think a nurse can help them. It's just that, you know, frankly, very often you do need somebody with the training to be able to say, oh, yes, it is just a cough. No, it isn't a sign of lung cancer. You know, and anyway, I'm ranting, but
it's getting the right people to the right place, isn't it?
Yeah.
I think my feeling about this, and I've just pulled up the slide with the turning the curve system-wide population indicators, the snappy title on, and I think I do feel it's a really good opportunity, because we have got system-wide indicators that are talking about smoking and alcohol and weight, and I don't think we've been in that position, certainly not whilst I've been around in Derbyshire. I don't think we've been in that position where we've got some indicators there really clearly talking about population health and prevention in that way. Okay. It's what we then do with that, isn't
exactly.
It? It's how we get that into action. But I do feel positive about that, and I think the other thing is around the engagement. As I mentioned, we've been in the conversation around how we ensure that the engagement is meaningful and joined up with all of the existing engagement that we've already got. And part of that will be, as you said, around translating this into something that means something to people's lives, isn't it? Because actually a lot of the strategy development is, as you said, about how we do it. Actually not what individuals will see that's different, or how healthier they will be.
Well, maybe that could be the next report then.
Yeah. And I think it's just, you know, it has got to be just really, really cognizant of the level of health need that we've got in the population and the deterioration in health. And that's what's partly contributing, isn't it, towards the challenges around getting a GP appointment, is actually not just the reduction in the number of GPs, but also the increasing demand and the increasing need in the population in order to see the doctor. And we've got to start taking action to make sure that people can stay healthier for longer. It's got to happen. Find a different way of managing it. So,
okay,
I am feeling positive about this. Good. I think it is a really good opportunity for us to have that different conversation.
Councillor Foggett?
I'm gobsmacked, to be honest, to find that it's took all this time for all these departments with the initials to come up with smoking, alcohol and obesity. are the three worst things that can ever happen. I've already struck out on all three, you know, and I've known this for the last 30 years. So I'm just amazed that they finally agreed on it.
What the change has been, and I think because we moved over as public health over here to the local authority in 2013. It's 10 years this year. In fact, it's just ticked over into April.
Happy
Isn't it?
birthday.
10 years that we've been here. And what happened at that point is that there was a great change in the way the NHS was organised, a splitting up and a real focus on acute contracts. Effectively, GP commissioning was taken off to the national organisation. And there was that move towards all of these things, they're public health, and all public health to local authority now. And it's been quite a long journey back, I think, to get back into that conversation about it's actually it's everybody's business, isn't it, these things? And I think we all know they're important, but nationally we're getting much more of a direction now around the importance of these things. And also the importance of us having that local decision making as well around health. So hopefully these things will continue on this road. I think we're making up for that lost time.
Yeah, I mean, I'm assuming Live Well comes under. Does it come under you?
Live Well is commissioned through the Public Health.
Yeah,
Yes.
I mean that is an excellent programme. I think that is really good.
We're very proud of
Yeah.
Live Well.
Yeah, it is good.
Okay, well, thank you, Robin. It looks a good report. It's full of acronyms. We look forward to those acronyms becoming some kind of entity that I can engage with, and also to, as you say, hopefully some of those health outcomes being a focus, which have the effects that you say. I would just stress, though, that I think not referring to food is a huge error in this, a huge gap, in this programme.
We will make sure, obviously that does come, you'll see that we've got the children and adults who are healthy weight in there, and you know that from the childhood obesity work that food comes very much within that, from the conversations that we had before, work around the food environment and things. So it is underneath.
It is in there, yeah, but it applies to everyone, not just the obese.
Yeah.
It is the key. It is arguably what is one of the key factors of people's health. Arguably even more than exercise, perhaps, but that's something else. But I do think it's something that people ought to be added to the list. But obviously, I realise this is a huge collective project, so I'll keep raising it anyway. That's depending if I'm still re-elected and if I'm still on these particular committees, so who knows what's going to happen. But anyway, thank you very much for that, Robin. Thank you for all your reports over the last 2 years. Very good. Right. So finally, we've got the work programme. Do we want to run through that, Dom, as we will be a different committee next year? I mean, we may be the same committee, but we could be a different committee.
I say the new committee might want a different remit.
Yeah, so we can't set anything that the new committee has to do, but there's a couple of items on the forward plan that I'll put forward to the new chair and take it from there.
All right. The possible new chair.
I was going to say,
That's
don't
right.
just to you.
I think that's the best.
I mean, for the new year.
Isn't it?
Yes, well, it's yeah, who knows? It will be the chair of next year, whoever that is. Thank you, because we have actually got some very exciting things and also some briefings lined up. So that's from people that are outside this kind of forum, we'll just have a briefing on things, which I think would be a good development for the committee next year. We do not have the topic review written up, unfortunately, so that's going to have to be deferral, the action of the moment, isn't it, until next year as well. So I think unless there's any other comments, I'd like to say thank you very much, everybody, and thanks for attending, and thanks for your participation this year, particularly in the topic review and coming to the meetings, and good luck in the election.